delirium. We'll get to depression another time. We talked about the dementia component last session, and we focused a lot of the dementia on just the quick overview of different types. Particularly, we were interested in what to do with the behavior. And this time, I'm going to be focusing on the delirium, and we can actually talk about the behavior management, because I think dementia and depression, the behavioral management is quite similar in that we should be focusing on what's driving the behavior rather than, what do I do to keep these patients sedated, which is, oftentimes easy solution. So let's keep going. Unless you have questions from last session, feel free to type it in the chat for everyone to see. Okay, I don't have any disclaimers, and if I end up mentioning a medication or a therapy, that's purely for demonstration purposes. So today we'll talk about the delirium, and I want you to really get just a sense, general taste of what delirium is about. Really, I want to spend most of my time today on how do we troubleshoot. Okay, so if you can open up the discussions, I think that'll be more worth your while rather than going through all the academic part of this. So let me get through the academic part real quick. Let's get to the meat and the bone. So delirium versus dementia, you've seen this slide from last time, and that there are some differences. Now you remember from the dementia, we know that there's more of a slow decline, like such as Alzheimer's disease, and usually it's a longer lasting issue, and that's a degenerative in nature, meaning that it's going to be progressive. And we talked about that. And as opposed to, you see that delirium is not so much. It's quick, and it's quite in your face, and it develops quickly. Okay, they look very different. And you will see that there's some small changes, subtle things that you will notice, such as their alertness, their orientation, their behavior, speech. There's subtle things that delirium is slightly different than dementia. This is a really good summary page, so I want you to hold on to this, but we're going to go through this together. Now, just quickly get through some of these things. Is delirium common? Just like we questioned, is dementia common? The answer is yes, dementia is common, so is delirium. So look at some of these numbers, and if you are older, okay, over 85, quite common in general population. 10% of the people are going to experience this at some point, and in medical setting, which is where we come in, is very, very common. Emergency room, up to 30%. Medical admissions, very common. You look at hip fracture patients, almost half of them have delirium at some point in their hospital stay. So it's very, very common. So I'm sure you've all seen delirium at some point. If you haven't, you just haven't recognized it, and you will. So do you remember this case? We came up with this fictitious patient named George, but I think we all know this George. He's 78. He lives at home with his wife. And then you remember the wife was concerned. She brought him in because he's forgetful, losing his keys. Remember this man? Yeah, so he's not dressing for the weather. He's just not functioning well at home. And he turns on the TV and he forgets how to do it, asks the wife, and he thanks her and asks for her name. So doesn't recognize her. And what happened is he got lost in the mall. So the police brought him in. And now basically he's brought into the hospital. Okay, so this is the part that I modified a little bit. Now he's emerged. He's agitated. He's almost hitting the nurse. She was trying to just put in an IV or put in a name alert bracelet, and he's swinging his arms. So do you remember this George from last week or ever in your medical career? You met this gentleman, right? So the flavor of the last week was that, I've given you different scenarios to make it sound like Alzheimer's disease, Parkinson's disease versus was it a frontotemporal dementia? I've given you different flavors, right? Now, what if I told you the same case was very sudden onset? It just happened in the last couple of weeks. Now, it doesn't sound so much like dementia we talked about last week. It's not this insidious onset, this gradual worsening. George was fine 2 weeks ago. He was playing cards with grandchildren. He was out taking the garbage out without prompting, which is, good for him. He was doing things around the house, so he was quite functional before. Now, 2 weeks later, this is no longer. Okay, so a few things should pop up in your mind. So this sounds like delirium, right? Just because the sudden onset of the situation. We're going to get into a little bit more detail. So is delirium bad? Well, yes, it's bad. Why is it bad? Well, from the patient's perspective, you could die from it. Mortality rate of delirium is very, very high. We don't really know because they seem to die from other illnesses at the same time while they're in the hospital. But 25% is what's been quoted, sometimes up to 75%. Okay. And usually they're in the setting of some kind of medical illness. And this is really bad. It's like as high as having a heart attack or dying from infection. From the family's point of view, the cognitive difficulties they have after. So, delirium, we used to think that, okay, this is temporary, and then you get better, and then you come back to normal. This is not the case. Most of the patients will find that they never fully recover, and a lot of the patients will take several weeks or several months to even recover to their new baseline. And from a hospital, the administrator's point of view, the length of stay goes up. I mean, if you come in for, say, pneumonia, urinary tract infection, you should really stay in hospital for a couple of days, 3 days, and then recover well enough to go home. But do they ever? No. The delirium makes them much, much more complicated for discharge planning. And of course, from the societal point of view, institutionalization, going to long-term care as a result of the delirium, massive. So pathophysiology, to be honest, we don't really know. There's some theories. There's maybe some changes in their hormone levels, maybe some inflammatory changes because, if you do a CRP level in the CNS when they do a lumbar puncture for other reasons, for academic research seems to be bad. And hypoxia, so it looks like some degree of poor oxygenation. The truth is probably a combination of all of the above. Okay, we don't really know, but it seems like something is happening in the brain as a result of this acute change in their medical status. So we always refer to the DSM-5, the new, the psychiatric diagnostic Bible, and they define the delirium as such. It's a disturbance in attention and awareness. Okay, so that this is a key. So your attention, and it develops over a short period of time. That's the part that's different than the dementia, right? And of course, similar to dementia, there's got to be some functional decline as a result of this delirium. Okay, I mean, we all get certain degree of delirious state if you're sleep deprived, for example. And I see a lot of you grabbing your drinks, caffeinated beverages in the morning just to help you expedite the wakefulness. But what happens if you don't get enough sleep? You just don't function as well, right? And imagine that being prolonged. So that's what delirium feels like. There's got to be some functional impact, okay? Disturbance in cognition. And this cannot be due to some kind of a other established illness. Like say you can't have dementia that can explain all the symptoms. Then, this is just a baseline dementia, right? And as I mentioned, some dementia sometimes fluctuate, can look like delirium. So namely Lewy body dementia we talked about, right? So unless it's explained by that, okay. And the last piece is you've got to do your medical workup when someone's delirious to see if there's an underlying cause of it. Okay, so different types of delirium. There's 3 different major types. One is everyone's familiar with, this hyperactive type. And we know about the hypoactive type when they're just not really interested in anything. And the most common by far is the mixed. Both of them, sometimes agitated, sometimes hypoactive. And have a look at this picture. It's kind of a funny picture. You see on the left, this gentleman's injecting some kind of yellowish liquid into her arm. Okay, no gloves on. That's ridiculous. And this gentleman in the back got her in a headlock. Okay, so that's it's a pretty standard restraint 101 in elderly. Good headlock and a choke. Yeah, and then you see the gentleman on the right. He seems to be settling the billing of the particular admission. So this is a picture, a depiction of how the patient in agitated delirium sees is happening, right? So what does she thinks is happening? She thinks that somebody is assaulting me and injecting me with poisons and stealing my money, okay? And I think this is a really good picture because it really tells you the perspective of the patient. So do you remember from last week's discussion that one of the best things you can do for a person with dementia and a dementia behavior is to look from their perspective. Why are they behaving that way? And in this picture really tells you they are behaving that way because of this. Let me give you an example. Okay, imagine yourselves, all of you. Imagine you're sleeping in your own bed. Okay, and then suddenly you wake up. There's a bunch of people in your bedroom. One person's trying to inject something, and one person's trying to take your clothes off. Okay, what would you do? What would be your normal response to that? Roll up the sleeve and help them with the vein? Do you help you show them where the safe is located? I mean, no, you will fight, wouldn't you? That's your normal response. So in the delirious patient's mind, when they're being assaulted, their normal response is to fight and protect themselves because they don't understand what's happening. I mean, in reality, that's not actually what's happening, but they don't understand that. That's the delirious cognitive disturbance piece. But they're getting back to the raw, normal fight or flight response. They want to fight back. Okay, so a lot of our behavioral response is going to be targeting that. How do we make them understand that you're not being assaulted? We'll talk more about this as we go. Now, what about this one? This is Mrs. Hall, okay, another factitious lady that's in bed. Let's say she came in with urinary tract infection, seems to be doing fine, except she just wouldn't get up. 3 days later, she hasn't got out of bed. There's nothing else wrong with her. All the blood work, everything's fine. She's just not interested in getting out of bed. What's happening? She sounds hypoactive, doesn't she? Yes, so hypoactive patients are trouble because they don't bother anybody. So nurses are not going to get alerted in the middle of the night, say, Miss So-and-so is sleeping, not getting out of bed. No one's going to alert anybody when they're not causing any trouble. And they can go under the radar for longer. And then what happens? 3 days later, you notice she hasn't really got up. Notice she hasn't really been eating. Notice she's not really engaging with you. We just thought maybe she was just sick. So that's the hypoactive delirium. They're just not interested in anything, just drowsy, just wants to sleep. Okay, a little bit different than just somebody who's sick and just tired and wants to rest. This is pathological in that it's really hard for them to wake up. It's really hard for them to be motivated. Okay, and the mixed is it's what you probably see, and you only would recognize the hyperactive part initially, but if you watch them carefully, in fact, they do have some hypoactive state, depending on what time of day it is. So how do we assess for delirium? This is a good tool called the CAM, Confusion Assessment Method. Has anybody used this? It's a toolkit. It's basically on admission or say once or twice per day. It's a nursing assessment tool, and basically you answer these questions. Question number 1, is there change in cognition that's acute onset or fluctuating in course? Yes or no? Okay. Number 2, is a patient inattentive? Inattention looks like, you're talking to that person, asking them to do a task, and they're just, oh yeah, they initially follow along and then they're distractible. Okay, it's like talking to a little child. Okay, oh, there's a butterfly, there's a squirrel. Okay, let's focus on this Foley catheter here. Let's focus on this pill you have to take. And okay, sure, they so distractible. Okay, inattention. Disorganized thinking. This is pretty obvious. This somebody who's talking nonsense. Okay, somebody who is previously well functioning and not making a good sense out of this situation. And number 4 is also obvious. Okay, somebody who's got altered level of consciousness. That goes all the way from agitated state, normal, and then comatose. So somewhere there. So normal being your alert normal level, but not hypervigilant. Okay, so you must have 1 and 2, which is basically the backbone of delirium, somebody who is fluctuating and inattentive. Okay, and then you should have either your thought processes or disorganized, or you're just not alert enough. So that's CAM. And the CAM score has been validated and happens to be quite sensitive and specific, more than 90%. And guess why? Because this CAM score is basically a summary of DSM-5 diagnostic criteria. So pretty powerful tool. Okay. So now it's lunchtime. It's 12:15. So one thing with the video conference is that I only see the black squares. I can't really see your level of consciousness, but we're somewhere here. Okay, so all of you with a black screen and muted microphone, I don't know what you're doing there. But this screen usually is quite interesting when we are doing this face-to-face, because it's usually lunchtime lecture, and I have a calming voice, I've been told. So make sure you all had your coffee. So I see some faces laughing. So okay, so you're around here, okay, alert. Now that I'm calling you out to your hyper alert and vigilant state, okay. So let's stay around there, okay. All right, any questions about this so far? All right, pretty straightforward, right? So I'm just going through this, zooming through this so we can have time to actually discuss stuff. Fully conscious, sure. I'll do some cognitive testing with you later, Kathy. Risk factors for delirium. So it should be obvious. Somebody with a vulnerable brain. That's the name of the game. What makes you vulnerable? Older age, okay, your baseline cognitive state. Dementia makes you more likely because, again, it's a vulnerable brain. Somebody with something in their brain that happened, like stroke, injuries or infection, what have you. Okay, it should be very obvious to you. Okay, and something that's making them sick at this time. Okay. And previous delirium is probably the most common risk factor. If they had surgery before they got delirious last time, very much likely this person is going to do the same thing. Okay, so let's talk about approach to a delirium. So if somebody comes in delirious, what do we want to know? So the first piece is that we want to diagnose that. Diagnosis of delirium is actually fairly simple. Okay, go through that CAM process, right? Is this acute? Okay, so it happened a couple of weeks ago for Mr. George. He was fine before that. Okay, and what is the course? So that meaning, is it something that just gradually just keep getting worse? Or do you think George is sometimes okay, sometimes it's better, but some other time it's just completely out to lunch, and then back to, he's all right. Sometimes he's agitated, he's a little bit more suspicious of people, alert, and some other times you just can't wake him up. He's just too drowsy, won't do anything. So that fluctuating course throughout the day and throughout the days. Okay, so that's the course. And then you wanted to give me some description about where is that disturbance? Is it limited to some kind of a cortical function, like say speech? It's limited to movement? It's limited to bowel function or something? Or is it more global, everything, which is more likely delirium? Okay, so you want to get that history. And then when you get that history, and then this is a problem, okay, then you make the diagnosis of delirium already. The delirium diagnosis is quick. The real deal is why. Okay, so that's when you get the background information. So get some collateral information. Do they have underlying dementia? Okay, what's changed? Are they eating and drinking well? Just a basic everyday day-to-day function. Okay, that's usually enough to put somebody into delirium if they have vulnerable brain. Something simple like they're not eating as much, they're not drinking as much. Maybe it was too hot yesterday, maybe it was too cold yesterday. Bowel movement. So this is something that we don't ask enough, bowel movement in elderly. Constipation can have downstream effect of everything we just talked about. You're just full of poop. You don't want to eat. You don't want to drink. You just don't feel comfortable. You can't sleep. Okay, so constipation is a major deal in delirium. And in fact, I made so many diagnoses of fecal impaction with this tool here. And it sometimes works like magic, just addressing the bowel movement. So I really want you to think about this. Okay, and bladder function, of course, especially those older male with large distended bladder, that might be a big enough reason to push somebody into delirium with a BPH. Really, when it comes to geriatrics, dementia, delirium, there's no shortcutting. You just have to just get the details and invest the time in early on. Same concept as dementia. Invest your time early on, and the process after that, it's much easier. So physical examination, so it's basically head to toe. There's really no easy way out of this. Okay, when somebody's delirious, something's bothering them, go through head to toe examination. Okay, but really I want you to focus on abdominal and bladder. That's a very common. A lot of the times their illness is very, very obvious. A lot of times they're not. Okay, a lot of times it's simple. Constipation. So let's talk about cognitive exam. Okay, so we talked about MoCA and MMSE last time in the setting of dementia. What do you think about that, MMSE or MoCA, in somebody who's delirious? Would you use it? I got a no. Unlikely, no. Okay. So I don't like to use MMSE or MoCA because what those tests are designed for is they're designed to screen for dementia. Somebody who's stable. So what happens is that you got a delirious patient, okay? Somebody who's not demented, just confused now because some kind of a medical issue now. You do an MMSE, they score poorly. They got 10 out of 30. What happens to that person? They get labeled, mislabeled as dementia, and then just propagates. And does that actually tell you anything? This person's MMSE is 10 out of 30. Does that actually tell you anything? Not really. It tells you that this person's cognition's off, but you already knew that. So that score 10, 12, is 10, 12 really different in person with delirium? I really can't tell you. I really don't know what that means. It's all it tells you is that something's off about this person's memory, okay? And that's really it. So there is the attention component of the MoCA and an MMSE that you might find useful, but then again, why do the whole thing? Why don't we just use that? That's what I would recommend. It's just not a very useful test when somebody's acutely delirious. So why don't you just take the component of the attention? Why don't we test that? So spell the world backwards. Okay, usually get into spell the world forward first. If you can't spell it forward, it's not a fair test, especially with the language barrier. Serial sevens is a good test. Okay, 100 minus 7, you subtract it again and again. Okay, if you can't do it at baseline, I know you're trying this right now in your head. So 100 minus 7 is 93, and 93 minus 7 is okay. Try it for yourself. Okay, it's a bit of a tough test. Attention to the orientation. Where are we? Okay, what time is it? What date is it? Okay, sometimes helpful, but some of the times if you're retired for 20 years, the day of the week really doesn't matter. What day of the week is it? It has no bearing in your scheduling. So some people it's not a fair test, but if they get it right, you know, that's pretty good. Now, tapping is a very useful tool that I use. So imagine we're having this conversation now, and you're listening to me, hopefully. Some of your eyes are closing. And I can ask you questions, right? Say, oh, where were you born? Or what brought you to the hospital? Okay, I'm asking you very straightforward, superficially routine questions. And what am I doing in the meantime is this. So I'm tapping. So usually side of the bed or side of a table or chair, depending on where I am. I'm tapping, making this noise as they're talking. So what am I doing is I'm creating an external stimulus to them. And usually what happens? What would happen if I was talking to you and I made that noise? You would see that's odd, that's weird, but you would just continue, right? You're able to shift your attention and focus on things that it's important. If you're delirious, oh, they're out. This tapping noise cannot happen unexamined. So it's a very useful tool to see how much they're able to pay attention to. So I use this all the time. Nobody will ever know that I'm testing them for delirium. I'm just talking, asking them questions, how they're doing, what did you eat for breakfast, how was your lunch, and then I'm tapping on the side. They'll think it's odd, but I get what I get what I'm looking for by doing that. Okay. Any questions about that? So usual investigations, get your blood work, okay? Rule out infection, chest x-ray, abdominal x-ray for constipation. I want to get a sample of their blood, cultures, if needed, drug levels. Usually you will pick up most of these. And if you're not getting the answer you need, of course you can expand the investigation to a CT scan of the head, MRI, EEG, and those things are a little bit more advanced, and I would only do it if you have a special reason to. Something on your story, like say they fell, they hit their head, or they're taking anticoagulant, they have a cancer history, something like that, okay? So I don't necessarily do it on every single person, especially the MRI. One caution is that every time we do investigation on a patient, there's a potential harm. And what that means is that, ooh, my screen changed. Can you hear me still?
Yeah, sorry, just 1 second here.
Yeah, I'm not sure what happened. My screen just changed.
Sorry. What is happening?
Sorry. Yeah, so the screen just lost the slide share. Not sure. Okay. How about now? Is it back to normal?
Yeah, perfect.
Yeah, I'm not sure what happened there. Sorry. What was I saying? Oh yeah, so the investigations can have harm. So for example, something as simple as I want to do a CT scan of a person. What harm could happen from that? Well, just the action of sending somebody down to the CT scanner can cause agitation. I mean, think about this. This person is now upset, agitated, and now what am I going to do? Send them to another strange place? They think they're being kidnapped or what have you, and that action alone can cause more agitation. So everything that we do has a consequence. So I really want to minimize them and keep them in a safe environment as much as possible. But sometimes you got to do what you got to do. Okay. So let's talk about the management. So this is where we should spend most of our time in. How do we manage somebody with delirium? Number one, by far, is to figure out what's causing it. Oh, Richard says he tried to share his screen and caused a blip. Yeah, well, you're lucky that it wasn't anything embarrassing on there. Where was I? Yes, so we should spend some time on this. I really want to open up the floor to have anybody has questions or a case they want to share with or have ideas, bright ideas to manage. Please jump in, because it really shouldn't be just a one-way lecture where I'm just reading what's on the slides. It's not what it's supposed to be. It should be a discussion, okay? Because there's no right or wrong way to treat somebody. Everyone's different. But the rule is, if something is causing the problem, you should fix that first. So usually a lot of the delirium cases are caused by something, like some kind of medical issue. And whatever that might be, we should identify that and we should treat that. And supporting this would be the supportive measures. I think supportive measures are just as important as the medical management. In fact, a lot of the times, supportive measures are the reason why somebody's in hospital or they can't stay at home. pain, somebody can't eat, so hydration, nutrition. Something simple like they're hot, they're too cold, bowel bladder function, okay? Those are important, and it might be frustrating, but keep telling them where they are. They keep asking where they are. You keep telling them. Reorientation, calendar, clock, window. Is it a day or is it a night? And the reason this is important is, again, just put yourself in their perspective. So remember that picture that I showed you, this lady on a wheelchair being headlocked and getting injected poison, being robbed, and they think that's what's happening. Okay, just think back to yourself, that situation where you're in your bedroom sleeping, you wake up surrounded by these people trying to do things to you. What would you want to know? You want to know what's happening. You want to know that you're safe. You want to know that these people are here to help you. Okay, and then you're going to forget, and you're going to need to know that again in a few minutes. That's what the delirium feels like. You're just in and out, in and out. Now, I've given you the example of a baby. So imagine you walk into a room to a crying baby. What would you do? It's very much the same scenario as a BPSD in dementia and delirium. I mean, the first thing you want to do is, well, is it my baby? Okay. Some of you may be still asking that question to this day, but let's imagine that's your baby, okay? Let's not pass the blame here. It's your baby, okay? And the baby's crying. What do we do? The first thing you should, well, remember we talked about this ridiculous practice of, okay, let's weigh the baby. So the baby is 6 kilograms. Okay, so it's 2 milligrams per kilogram body weight. So 12 milligrams of IV injection of sedative. No, we don't do that, right? But guess what? That's what we do in hospitals to people with dementia and delirium, right? So remember we talked about this same scenario in delirium. If a baby's crying, you should figure out what's causing this problem. Why is a baby upset? Why is she crying? Is it hunger? Is it thirst? Are they cold? Did they poop? Or they can't poop? They can't pee? Or they just peed? Right? You will investigate. Simple supporting measures go a long way. Okay, so that when baby's crying and thrashing about, it's cute. But when a 78-year-old previously healthy man gets upset and agitated, it gets sometimes scary. And hence why we're using a lot of sedatives before we even address the issue. Okay? So I really want you to think about that. Now, along the same line, I really want you to think about the things we do, so iatrogenic, the things we as healthcare providers do to the patients that makes them agitated. Okay, restraint. By far, number one risk factor for prolonged delirium is restraints that we do to people. I don't mean restraints as in, they're in handcuffs or they're locked down, but medical restraints. What am I talking about? IV. Okay, you're stuck to the IV pole. You're stuck to the blood pressure cuff. Oxygen sat. Foley catheters. I mean, would you not get upset if you find out you're waking up in the middle of the night, somebody's sticking a tube into your genital area? Right? This is what these delirious people see. Their perspective. Okay. Do you really need that catheter? Well, they're incontinent. Okay. Well, we can use diapers for the short term. Can you use something less invasive? Right? Does it really need the IV fluid? Well, can we make it intermittent? Right? Do you really need that blood pressure cuff on at all times? Right? Those are the kind of the things we can do. Minimize the restraints to them. Yeah, so Annie's sharing with us, 81-year-old gentleman with agitation, delirium, mild cognitive impairment, put on nausea 50 milligrams, okay, heavy dose. Risperidone, 2 milligrams BID, again, heavy dose, okay. So that's a common scenario, right? So this is, to me, same thing as, we see a baby crying and we do a body weight or body surface area dose of sedatives, okay? Before we do that, sometimes we need to, right? Sometimes they're just too agitated, dangerous. Sometimes we need to, but what I'm saying is that before we do that, okay, let's make sure that there's nothing driving that behavior that's reversible. So let's talk about these sedatives. So what do we use? Antipsychotics, benzodiazepines. Really try to avoid these as much as possible. The benzodiazepines, for obvious reasons, I think it's common knowledge now, benzos are not good for you. But if they're in withdrawal, say like alcohol withdrawal or benzodiazepine withdrawal, in that case, you should use it because that is the cause for their behavior, the withdrawal. Okay. Other than that, let's try to avoid it. So remember in dementia, we talked about why antipsychotics are so bad. We talked about their mortality rate. It seems to kill people from stroke, heart attack, aspiration, falls. So antipsychotics are really bad. So the way I see it is like this. It's an antipsychotic, right? What do you use antipsychotics for? For psychosis. So the question, are they psychotic or are they not? If they're psychotic, we should use antipsychotics. It's a good indication for it. What I mean by that is this. Imagine this gentleman, George, is agitated, he's upset because he's hungry. The treatment for that is food, right? But what if George was acting this way because he's seeing things, there's blood dripping on the wall, or he thinks there's a butcher coming to get him, like he's fighting for his life. And the nurse comes in with a needle. What's his first thing? Yeah, this will show you, right? George is fighting for his life in his mind. So that's psychosis. He's delusional, he's hallucinating. In that case, what's the treatment for that? He's psychotic, antipsychotic. Make sense? It's very straightforward. What's driving that behavior? We treat that. Okay, so there is clearly a role for antipsychotics. So risperidone, Nausinant, Haldol, all these medication, there's clearly a role for it if they're psychotic. Make sense? But for the rest of those patients who are simply just trying to get by because they can't meet their physical needs, then antipsychotics is not the therapy. Does that make sense? Okay. So we talked about this last time briefly, but let me look at it from a delirium angle. There was initial studies early on that thought, oh, these people going through surgery, they seem to be delirious, and once we give them antipsychotics, they seem to be not as agitated. What happens if you give it to them before they get delirious? Let's check it out. So they did trials early on. Guess what happened? So before your hip surgery, I give them Haldol. What do you think happened? Nothing good came out of that. People are falling, they're aspirating. So, I mean, it's a common knowledge now that we shouldn't do these, but back then when we were just trying this, we had to get data, and data we got. So bottom line, medical, surgical, critical care patients, prophylaxis with antipsychotics did not work. In fact, they showed mortality and severe morbidity, falling, aspiration, just frank death. We talked about that, right? So bottom line, don't do it, okay? So then, what do you want me to do? What can we do? It turns out, what works for people with delirium or preventing delirium is good care. Okay, sounds pretty obvious. So it turns out providing good care has a significant benefit in reducing delirium risk, like before they get delirium, okay? And also when they have delirium, they have better outcome. So what am I talking about? What's a good care? Well, good care means that, when you're at home, you're feeling well. Okay, what does that mean? Sleeping, you want to sleep well. Okay, you want to eat well, you want to drink well. You don't want to be uncomfortable, no pain, you're warm, okay, and you're not stressed. That sounds wonderful, right? So what does that mean in real life in a hospital setting? So sleep hygiene. Oftentimes, a sleep hygiene is disrupted because we're doing vital signs in the middle of the night, or we're giving them medications in the middle of the night, okay? We're doing some procedures, or there's noise in the hallway, things like this. So it turns out, if we have a good initiative where we minimize noise at nighttime on the unit, so turn off the light, dim the lights, okay, and close the doors, and all those beeping noises, they're minimized, they sleep better. And as a result, they sleep better, they have less incidence of delirium. Do we really need to get that vital signs at 3 a.m.? I mean, some people do. If you're ill, yes, you should, absolutely. But for those of you who are not critically ill, do we really need that vital signs Q4 hours? Right? That's something to think about. So if you're the physician, don't do it. Change it. If you're the nurse looking after this patient, bring it up. Right? We should use our common sense. Imagine you're sitting in that bed, okay? Would you want to get this vital signs? Would you really want to get this blood work at 5 a.m.? Is it really necessary? Right? Good care, okay? And that IV that's running, that's tangling up every time, the oxygen they're on, do they really need it? That Foley catheter, do they really need it? Question it. Now, a big thing, eating. We have this very strange culture that when you go to the hospital, you seem to eat breakfast in bed 3 times a day. It's a very strange culture that we developed. So it's like the sick person mentality and sick person culture, right? You go into the hospital, you see patients on the bed, right? Some of them need to be on bed. They're too weak, or they got cardiac problems or something that makes them bed rest. And sure, situation calls for it, you should do it. But the rest of them, why are they in bed? You don't spend your whole day in bed normally. So why does a sick patient need to spend their time in bed? Can they walk? They should walk. Can they sit up? They should sit up. Can they sit on a chair? PJ paralysis. That's a good description. So as soon as they come into the hospital, they just become bedbound. Okay, and this is something we should definitely address. Why would you do that to somebody? Now, what's the bad thing about it? Deconditioning, right? So you've got 1 day, 24 hours in bed. It's equivalent to about 7 days of rehabilitation to get that muscle back in your catabolic state when you're sick. Major problem. Okay. And what about delirium? What's a bad thing about delirium and hospital is that you're bored. Oh, has anybody quarantined yourselves during the pandemic? Yeah, just staying at home. How did that feel? Now imagine you stay in bed for 7 days. Like, I don't mean like quarantining in a house, but like staying in the bed. How would that feel? Bored? Nothing to do? Right? Strange thoughts will come to your mind. And guess what? If you're in hospital, that's what happens. In between your blood work, in between your care, in between your doctor's 2-minute visits, they got nothing to do. Yeah. And if they're disoriented, they're in this room, like kind of like mine. I don't know if you can see this. There's nothing around here. I'm just sitting in my bed all day for 7 days, nothing to do, nothing to feed my curiosity. Then what's going to happen? Is they're going to lose their sight, orientation? Major problem. So what am I saying? Give them something to do. Entertainment, okay? That be as simple as reading material. That worst case scenario, TV. okay? Family phone calls, but more importantly, physical things, sitting up. Okay, you should never have patients sit in a bed for meals unless there's a medical indication for it. Why would you get breakfast in bed 3 times a day? You shouldn't. Okay, normalizing their lives seems to make a lot of sense. So it sounds like very simple things to do, and does it actually work? Well, it turns out yes. So there's a Cochrane data of multiple small interventions. We talked about this. Okay, they're really simple. It's just providing good care, normalizing their hospital stay like normal life. And turns out there's a lot of trials. There's 39 trials. And what they found is that, oh, okay, so it turns out it works. So their risk of delirium goes down if you provide them with good care. Walk them, get them to walk early, give them a calendar, sit them by the window if you can, having a clock inside, okay, so that they can sleep at nighttime with a reduced noise, turn off the lights, and getting rid of this IV catheters and all this stuff. So it's a multi-dimensional intervention. But really what I'm asking is really just providing normal good care. There's nothing here that's really just out of the ordinary, right? So the key to this is put yourself in their shoes. Okay, just imagine yourself being in the hospital bed, okay, for 7 days. What would you want to do, right? And that's where this study comes from, okay, providing good care. Okay, so it turns out their relative risk goes down to 0.73, okay, and their p-value is less than 0.001. I sound really smart when I put up some numbers here, so I just did that. But basically, bottom line is that it seems to work. Okay, so summary here is that delirium, the best thing to do is prevent the delirium by using this non-pharmacological measures. Once they set in, then you want to get the diagnosis as soon as possible and identify what caused it, some kind of medical problems. And then after that, okay, try to avoid using sedatives, try to avoid using restraints. Unless they're psychotic, then you want to use antipsychotics. Okay, unless they're agitated to a point that they're at risk to self or others immediately, then you want to use it. But somebody banging on a table, making loud noises, is not somebody who's at risk of harm to themselves or others at that moment. That's not the reason to be using antipsychotics. Okay, so I think at this point we should talk about specific troubleshooting. Anything from the audience want to bring up? Like Annie, maybe this gentleman you brought up. Do you want to talk about this person?
Yes, thanks for the question. This is an 81 gentleman with been seen by the GAT team actually twice, first in 2016 and the next 2017, and was diagnosed with not exactly dementia because he didn't meet the criteria of functional impairment. But anyway, the current status is that he has also psychiatric history as well as previous suicidal attempt like wrist cutting and all that. And right now he's at frequent event of elopement out of the hospital compound. And so what happened was that the risperidone is being increased to like 2 milligram BID. And this person has been getting the Nozinan 50 milligram HS for a pretty long time. So I just have concern about having these two agents together, them being antipsychotic, and there are observation that patient is making some tremors, you know, on the lower extremities and stuff like that. So I'm just kind of wondering about this part of it.
Sure. So not knowing all the details of the person, I won't get into the specifics, but let's talk about general concepts associated with this case. Yes, okay, good comment from Richard there. Yes, vitals, Q4 hours while awake. Excellent idea. So let's get back to this gentleman. The concept is this: when somebody is having psychotic or psychiatric issue that's driving this behavior, then the correct thing to do is to address the psychiatric condition. In that case, antipsychotics, antidepressants, or mood stabilizers, what have you, is absolutely the right way to go. Because we're not dealing with situational or environmental issue driving the behavior, right? So that's the key component. We got to figure out why somebody acting that way. Okay. So this gentleman is diagnosed with a psychiatric illness, wants to elope. We have to figure out why does he want to elope? Okay, is he trying to go to a place, or is he trying to get away from this place?
Yeah, I think he's a very strong driving desire to go home. And in some ways, his behavior is a little bit manipulative in a sense of, if I may say, it's a bit of attention seeking. So, and very, how to say, depressed and sad mood, thinking that his family doesn't want him. And that's very upsetting for him. And this kind of like driving all this behavior as well.
Okay, so again, I think that spending the time to gather that background information, again, coming back to why is the crucial piece. So if I could really simplify this case, this is a gentleman who's got certain need that's not being met. So the emotional need sounds like, and reason for this behavior is to meet that emotional need. So that emotional need can be met with medications, some part, maybe can blunt the response, but really that's not going to fix the issue. So it's going to be troubleshooting. So how do we make him feel that he can meet his emotional needs? Well, start with things like, okay, attention to him, right? We can provide this attention, family, okay? It could be direct human attention, like somebody calling him, somebody doing video conferencing, check-ins, okay, regular schedule, so that he has something to anticipate. So let's say at 7 p.m., someone's going to call. Okay, so that would be a good strategy. And non-personal things, so like photography, having an album, or usually people would have phones now, or like tablets now, having videos and things like this usually helps quite a bit. So we have actually in Vancouver General, we have started a project with an iPad, so the family can bring in photos and videos and then just film themselves and then play it on a loop. So this is usually for delirious or demented patients. So it sounds like this gentleman's got more cognition than that. Yeah. But the concept of this is still the same. His needs are such that he wants to have this emotional companionship. Maybe having a pet is another option. So there's a few things that we can do beyond the antipsychotics. So again, the key component here is that we want to address the underlying need, and that takes time to figure out. Okay, so I hope that's in general helpful. Okay, anything else?
Hello, Dr. Lee. This is Aus.
Yes, go ahead.
Thank you for your lecture and precious information. I have a simple question. We know that constipation is a big issue in delirium and in elderly. The definition of constipation, I mean, we know that elderly, they have sometimes less frequent bowel movement. And so how we describe the constipation for them and how we approach them? Shall we do, just ask about the the patient baseline in terms of bowel movement, or shall we do a rectal exam, digital exam, or do an X-ray to confirm the magnitude of the constipation?
A lot of these patients don't remember, and they're delirious, right? And I don't trust them. And the abdo exam sometimes doesn't really help you very much. So I do usually two things. One is a digital rectal exam, and you'll be surprised how often you find fecal loading and fecalith, very, very commonly. Okay, so previously highly functioning people, much less so, but someone with an underlying cognitive impairment, so more vulnerable population, absolutely, absolutely. Okay, they even come in with diarrhea, and you know what that diarrhea is from? Overflow, right? Very, very common. So digital rectal examination, I found so many cases that I'm a big believer that everybody who was delirious and who's capable of participating with this exam should get it. And if they can't, I'll get an X-ray. It's common enough that the yield actually has been quite high for me. So I'm not looking for somebody who hasn't pooped just in 2 days. I'm looking for somebody with a fecal loading, right? You wouldn't just get constipated mildly and get into delirium, but I'm talking about fecal loading. So it should be pretty prominent on your X-ray. Okay. Richard's asked me a question. In Emerge, what we do, Haldo, with or without Ativan, combative patients. So Ativan, let's talk about benzos. So the pharmacology of the benzo is very similar to alcohol, right? And we all know what happens when a person drinks alcohol. Their frontal inhibition is removed. So what happens? They get belligerent. So the impact of the benzodiazepine is that if you push them to a certain threshold, the sedative impact will kick in so that they're just too drowsy to be combative. So that's what we're trying to use. But the dosing of that is such that if you underdose them, what happens? They become belligerent. The agitation gets worse. And then it will set in. As it wears off, the agitation also gets worse. And it makes you, I don't know if anybody here ever got intoxicated, but you just can't think straight. You're already disorganized. And then what happens? You give them a bottle of scotch. And that's what Ativan is. So I strongly stay away from the benzodiazepines unless the reason of the delirium is the withdrawal from benzos or alcohol. So then what do we use instead? Okay, so again, we should spend a little bit of time to assess, okay, is this person agitated right now because something is driving them? Or they're just so dangerous right now, I just cannot have this time to assess this. I need to control the situation now. Okay, in that case, you're using some kind of sedative antipsychotic. So you're not using it for antipsychotic property, right? You're using it purely for the sedative. So you should use something that's make you drowsy. So Haldo, so if they can take it by mouth, okay, that's one option. I usually like to start with quetiapine because quetiapine has the least amount of the Parkinsonian side effects. And also that if they can take it by mouth, and that's the safest in terms of their morbidity, mortality rate. So that's what I start with. How much do I give? Not much. The frail lady, 6.25, tiny dose. Okay, that's a very small dose. So you might use a different dose for younger person or psychosis, but frail elderly with delirium, tiny dose, 6.25, 12.5. That's it. Usually it's enough. But if you're using these agents, if they are not willing to take something by oral, well, then you have to use something IV or sometimes IM, right? In that case, Haldo, 0.5 milligrams. My doses are very, very small, 0.25, 0.5 milligrams. The key is small dose, frequent injections. So oftentimes, very, very oftentimes, you give them a small dose, okay? And it takes some time to work, and then you give another dose, eventually works. But if you give a big dose and they're completely knocked out, you can't really come back from that. They're knocked out for the rest of the day. And then you prolong this delirium, right? So there's a downstream effect from it. So recommendation is simple. Avoid from benzos. And if you're going to give something sedatives, try by mouth, small dose quetiapine. And if you have to give something by injection, then Haldol, small dose, 0.25, 0.5 milligrams, frequently, small dose frequently, Q30 minutes, Q hour. Avoid big doses. 2.5 milligrams to 5 milligrams in a young person might be fine, but in an older person, that might be enough to knock them out for 24 hours. Okay, hope that's helpful. So the bottom line is behavioral issues. Really try to get to the bottom of what's driving that behavior. Usually ask them, okay, go through exam head to toe to see if there's something obviously bothering them. Treat them like an infant or toddler who's upset and agitated. Provide them with usual good care. Normalize their life in the hospital. That's how you fix delirium. And antipsychotics are only used for psychosis. You should treat that. Or somebody who is just so agitated to a point that you cannot control it. And have some patience. Usually delirium will get better with time. I hope that's useful to you. And there's a slide that compares the dementia versus delirium. Okay, but the real key component was that discussion that we were having. What do we do in this case? Any questions last minute? Okay, thank you. I'll see you again with another topic.
Thank you, Dr. Lee.